Thank you very much. A friend of mine did say that I'd given up ethics to be a lawyer, but that's not strictly true at all. Yes, well, there are a huge amounts of ethical issues relating to truth-telling in medicine. There's the issue, of course, of patients lying to doctors, an issue that's been going on for ages. If you read some of the Hippocratic texts, some of the authors warn doctors to watch out for the lies of patients. There's the issue of doctors or clinicians deceiving each other. And there are some examples of that in hospitals when you request a scan for your patient and you want it a bit quicker, and so you might put query PE in order to get the scan quicker, or you want a patient accepted onto a ward or so on. And there's also, of course, clinicians deceiving patients in order to protect themselves from blame. They're all very interesting areas of ethics, but this evening I want to talk about the issue of benignly intended deception or benevolent deception. So when doctors deceive patients in what they believe is in the best interest of the patient. Now, the codes of ethics of these respected institutions may be a good place to start to find the answer to the question of whether doctors should always tell the truth. And the World Medical Association says doctors shall deal honestly with patients and colleagues. The General Medical Council be honest and trustworthy, it says. The American Medical Association says a physician shall be honest in all professional interactions and strive to report physicians engaging in deception to appropriate entities. So if you looked at these codes of ethics, you might think that I've wasted several years of my life doing a PhD on this topic, because the answer is perfectly obvious. Of course, doctors should always tell the truth. Look, it's written in all these codes. But in the next 45 minutes or so, what I want to persuade you is that actually that's wrong, and that it is at times morally acceptable for doctors to lie even to their patients. And in 2007, I wrote a piece on this topic in the British Medical Journal. And not everyone was impressed. These are some of the comments in the rapid responses. Daniel Sokol's article is deeply disturbing. Standard medical ethics are quite clear on this point, and it's a shame that ethicist Daniel Sokol is not. This is my favourite. I simply refuse to read the article, says this nurse. Yeah. So people do feel very strongly about this. Now, if you look back at the issue of truth-telling, the debate does go back to the ancient Greeks. Again, the Hippocratic texts, you find some essays, as you'll know, they were written, the Hippocratic essays were written by different people. In some essays, the author says, do not tell a patient if there's something bad, because he might actually make a turn, take a turn for the worse if you tell him bad news. And then you have another essay, there's one called On Head Wounds, that says, look, if the patient's going to die, you've got to tell him. So even then, there were disagreements about when it's appropriate to tell the truth. Plato, interestingly, had this theory that lies were akin to drugs or medicines. And if you thought it could help your patient, then you should use them. And it was negligent not to use these therapeutic lies if you thought it could help your patient. I found this book in a small bookshop a few years ago, Law and Ethics for Doctors, 1958, and there was this passage in that one. It is customary and indeed often clinically wise and in the patient's interest to withhold certain matters from the patient. Examples are the fact that a patient has some incurable disease or that his condition is such as to hold out little hope of recovery. And there may be people in this room who, when they practiced, in the 50s or 60s, even the 70s, remember that it was actually fairly common back then to withhold certain information, perhaps about a grim diagnosis, to patients. And it's still the case in many parts of the world. And I encountered this firsthand, again in 2007, when I spent some time with a general surgeon in Tamil Nadu in South India. And the first patient, the first operation that I saw was an above-knee amputation. on this diabetic gangrenous patient, gangrenous foot. And it was all very interesting. The foot was removed and it all went well. And in the taxi the next day with the surgeon, I told him, look, I'm very interested in medical ethics, and in particular, I'm interested in truth-telling. And he goes, that's a really interesting subject. Because you know that chap whose leg we amputated yesterday? He didn't know we were going to amputate his leg. He didn't want the operation. So we had to trick him into it. And everyone was in on it. His wife, his adult children were all in on the deception. And as I said, there are many parts of the world where this is not uncommon. And for this surgeon, I mean, he didn't articulate it in that way, but you can imagine what his argument would be. It would be an argument based on beneficence. So look, this chap is medically pretty unsophisticated, and I know what's best for him. And if he didn't have this operation, he would die. So beneficence for him would be the driving factor. This is a real case that hopefully should give some flavour of the ethical complexity of this topic. And interestingly, I've come across this case since I did my PhD. This is a real case that took place in Canada, but a few years later we had an almost identical case in a London hospital. So this is the example that I use. I mean, I've kind of anonymized it and simplified it because I wanted to show this example to different groups, including lay people. So Susan, who's 18, wants to donate a kidney to her father, John. John has a life-threatening kidney disease. Both are very close to each other. And during routine blood tests, doctors discover that John is not in fact Susan's biological father, although Susan could still donate her kidney to him. The mother is out of the picture in this particular scenario. I think they're divorced, lives out of the country. So the question then is, well, should the doctor tell this information to Susan and her father? And what I usually do here is I take a vote. So please don't be swayed by the answers. There's not necessarily a right or wrong answer. So could you put your hand up if you think that the doctor should withhold this information? Just withhold it. Okay. And who thinks that they should tell? They should disclose it? Okay. Probably about 80%, 70-80% would withhold it. And of the people who would withhold it, who thinks that that's a form of deception? Hands up if you think that that is deceptive. No. You put your hand up and then you change your mind. Yeah. Okay. Okay. All right. Now I put this scenario to a number of different groups. This was in 2003, I think. I asked doctors and patients and members of the public, and you can see that actually there are roughly similar results across all three groups. Sample sizes are fairly small, but it does give you some idea. And most people, actually probably a little bit like this room, believe that you shouldn't tell them. Well, what kind of arguments would you put forward in favour of your position? Now, I know there's at least one professional ethicist here, but one of the ways in which medical ethicists would, one of the ways in which they would approach this problem is by using the well-known four principles approach. I don't know if you're familiar with the four principles approach, but in essence it says that there are four fundamental moral, ethical principles that regulate all of medicine. Some people say life generally. But here the four principles are beneficence, the duty to do good, and non-maleficence, that's another one, the duty not to cause harm in your patient. Okay. And so looking at these principles, what would you say in constructing an argument against disclosing this information? And you would say, in my view, that actually telling this information would cause more harm than good. And the reason is because it may cause considerable distress to the patients. It is possible, although unlikely, that the daughter, upon finding out this information, might refuse to donate the kidney, which would almost certainly mean that her father, non-biological father, would die. It's possible that the father might decline to take the kidney upon finding out. This family unit, which has hitherto been so tight-knit, may disintegrate. The morale of the transplant team, again, may be damaged, and if the patients are outraged at having been told this, they may lose trust in the transplant team. That's also perhaps a form of harm. Another well-known principle in this country, anyway, in many Western countries, is the principle of respect for autonomy. So allowing people to make decisions based on their own beliefs and values. In this country it's tremendously important, so a patient, as you know, can refuse life-saving treatment if he wants to, for no reason at all. Whereas in rural Tamil Nadu, respect for autonomy is less important. In fact, in many cultures where the family is more important than the individual, they talk of respect for family autonomy taking precedence over respect for individual autonomy. So you now have countries like China who have kind of Confucian approach, and they say, gosh, you Western people, you have such an atomistic understanding of autonomy. The family is much more important, or even the village. But in this culture anyway, respect for autonomy is an important principle. And under that heading, you might say, if you didn't want to disclose it, you can say, well, there's no violation of the principle of respect for autonomy because there's no duty to disclose this information. The purpose of the tests wasn't to find out if there were father and daughter, it was to find out whether or not that that transplant was possible. Or you might say, well, okay, there is a violation of patient autonomy, but it's a justified violation. So these four principles, they're not absolute, they're what's called prima facie. That means they're binding unless they conflict with a stronger principle. And in terms of justice, you might say, well, there's probably no legal or moral obligation to tell. The principle of justice is probably the most complicated one, of acting fairly and distributing resources fairly and so on, and respecting the law and respecting rights and so on. We've had a very eminent group of doctors here, and the majority think that you shouldn't tell. So even under the Boland test, it would succeed, although there's the Belitho problem possibly. A judge may say, well, I don't care what these doctors think, it's ridiculous not to tell the truth, who knows. So that's the way you would approach this problem, using the four principles, if you wanted to justify not telling. Again, if you wanted to try to explain why it was important to tell this information, you would use the same principles, but you would interpret them differently. You say, well, actually, if you look at beneficence and non-maleficence, in the long term, it probably would cause more good than harm if you told them. Yes, of course they'd be distressed, assuming they don't know initially, but the fact that they'd be distressed initially isn't a good enough reason not to tell them. That's the excuse that people used to give for not telling people they had cancer. They thought it'd be too distressing. They may say that the likelihood of the daughter not donating her kidney is very low, and they're very close to each other. Is it really going to make her change her mind? And what if they find out later? What if there's a blood test or something that they need later on, and they find out that they've been deceived all this time? And then in terms of the medical team, because they also factor in all these principles, the distress at withholding the truth, it may be quite distressful for some members of the medical team not to be able to tell them. It's much harder these days to deceive patients because you have such a large multidisciplinary team and all these notes. Everyone has to be very coordinated to make sure things don't slip out. But in the olden days it used to be simpler. Okay, so it's unclear perhaps which of these two horns of the dilemma will cause more good than harm. But what about for respect for autonomy? There you might say, if you're pro-disclosure, that actually it is relevant, potentially relevant, to the decision to donate. And medically, it is relevant, because if she donates her kidney, she puts herself at harm and may do probably will do good to her father. And if she refuses to donate, then she'll maintain her own physical health but put her father at medical risk. It may alter her self-concept. It may even affect her decision to have children. She may think this is genetic. And in terms of justice, you may want to say that she has a legal and moral right to know. And you may even point out that how can they get proper consent for this if they don't reveal this potentially important information? Would it be true, valid consent without this information being disclosed? So I'll tell you what happened at the end. I'll keep you in suspense, and I'll wake you up at the end to let you know what actually happened in this case. Right, well, why is it important to tell the truth generally? The obvious answer is that truth-telling is essential for the functioning of society. There has to be what's called a truth bias, an assumption that when you communicate with people, unless you're playing poker or have got special circumstances, people will tell you the truth, and even lies rely on this truth bias in order to lie successfully. And then also, as I mentioned, respect for autonomy. Autonomy literally means self-rule. It used to apply to states, but then it was transposed into individuals as well, the ability to lead your life according to the way you want to. And in order for that to happen, people need to feed you correct information. In the context of medicine or medical ethics, why is it important to tell the truth? Well, it's almost a truism now, but people have different conceptions of what counts as a benefit to them. The hackneyed example is the Jehovah's Witness. So for most of us, if we had an accident, we would want a blood transfusion. That would be a benefit to us. But for a small group of people, the Jehovah's Witnesses, that wouldn't be a benefit. And you have the same kind of thing with the end of life, when for some people they want to fight till the bitter end, and for other people they'd rather not be on life support for longer than absolutely necessary. So patients are generally the best judges of what is best for them. So the idea is that you give them the information and they can make their own decision. The second point is an empirical one, in that in this country the research shows that most patients do want to be told the truth, even if it's grim or unpleasant. The third one is often given in textbooks, but I think it's probably a little bit more complicated than that. The trust in the doctor-patient relationship really relies on this idea of truthfulness between the parties. The reason why I think it's more complicated is because when one thinks of the golden age of doctors, probably I would say 1930s, 40s, 50s, when they were held in the highest esteem, deception was rife, but yet trust in doctors was sky high. So I think that the secret is not being caught in your deceptions and in your dishonesty. But it's an interesting thought that deception was rife in the 40s and 50s, yet trust was very, very high. And then the idea of truthfulness as a virtue. So there's some ethicists, I talked about these 4 principles. The ethicists who really are very keen on these principles, on analysing problems, ethical problems with these principles, are called principlists. Okay? And there are other groups of ethicists who consider themselves virtue theorists or virtue ethicists. They think, the right way to approach an ethical problem is to ask, well, what would a virtuous doctor do in the circumstances? What would a virtuous orthopedic surgeon do in this situation? That's a better way to approach it than thinking about, what's beneficent, what's non-maleficent. And when one thinks of, well, what are the virtues? Actually, I think you probably do this with medical students. What virtues do you associate with a good doctor? And they'd say, conscientiousness and thoroughness. But most people in that list would put honesty. And so that's one of the reasons why you want to tell the truth, because the conception of this virtuous doctor contains honesty as a virtue, an honest clinician. So those are the reasons why it's so important to tell the truth. What's interesting is that in reality, in everyday life, we often don't tell the truth. So how do I look? Asked the girlfriend wearing this non-exchangeable, non-refundable, quite horrific dress. If you want the relationship to be going, you say you look great. Or you're invited to someone's house, you taste the food, to your horror it tastes like feet, and the person asks, how does it taste? Well, if you want to be invited again, you say it tastes very nice. Or you leave, you get out of Liverpool Lime Street station, and some homeless person asks you if you have any change. And your pockets are jingling with change, and you say, I'm sorry, I don't have anything. Yeah? Or even, a few weeks ago, this mass deception of Father Christmas. And the tooth fairy and so on. David Dyberg, who's a philosopher, wrote, "It seems to me that communication absolutely free of deception of all kinds is suitable only for people who like each other very little or don't plan to be together very long." It's an interesting exercise to consciously note down how many deceptions and lies we utter every day. Now, most of the lies that we do tell are fairly trivial, what we might call white lies. But occasionally, a failure to deceive can have quite serious consequences. I remember reading in the Metro, that's a famous scholarly newspaper, a few years ago, of a teacher in the Midlands being sacked for telling her 9-year-old students that Father Christmas didn't exist. But at the more extreme end of the severity spectrum is the refusal of some British military generals in years past to use surprise and deception against the enemy. So among some decision makers there was that attitude of, well, that's not cricket, or we can't possibly do a surprise attack on the enemy. And there's a famous book by Norman Dixon called On the Psychology of Military Incompetence that specifically notes the refusal to use deception as an element of military incompetence. Lying is just one way to deceive people. When people think of deception, they think of lying, but I could have done that trick without saying a word. It could be completely non-verbal. You can deceive people with smoke signals, with gestures. And it also shows that deception doesn't necessarily need to be morally bad. Hopefully you didn't feel morally wronged there at having been deceived. It's possible to tell the truth while still deceiving someone. And I draw a distinction between telling the truth and being truthful. And there's a well-known example by an Oxford philosopher, the late Oxford philosopher Bernard Williams, of this employee who really dislikes his boss. And whilst his boss is away, every day, every morning, he goes to his boss's pigeonhole and opens his mail, just out of curiosity. And at the end of the week, the boss comes back, and the employee runs up to him and goes, "Boss, you won't believe this. Someone has been opening your mail." Which is absolutely true. It's a true statement, but plainly it's deceptive. Okay? Because that someone is him. You know, he should have said someone's been opening, and it's me. But no, he just said someone's been opening your mail. It's not lying, he's saying the truth, but nonetheless it's deceptive. And there is an expression, why lie when the truth will do? Yeah. So one way to conceptualize deception is by using what are called Gricean maxims. And Paul Grice was a philosopher of language in the 1970s, and he came up with this theory, this idea of the cooperative principle, which is when we talk to people, again in normal circumstances, not when we're playing a particular game, there is an assumption that your interlocutor is going to be cooperative, is going to be helpful in his interaction. And you can break down that cooperative principle into 4 maxims. The maxim of quality, which says you should say what you think is true. Okay, we assume that that's going to be the case. The maxim of quantity, which says say as much as is required in the circumstances. Okay? And we all can gauge that. And if people can't gauge that, it becomes very strange. You meet someone on the street and say, "Oh, how's it going?" And they stop and talk to you for half an hour. They've kind of violated the maxim of quantity, because for that it's not appropriate in that particular interaction. Relevance, be relevant, and the duty of manner, the maxim of manner, be clear and avoid ambiguity. So when we speak to people, we assume they're going to respect these 4 maxims. It's just taken for granted. Now what that means is that you can use these assumptions to trick people, to deceive them, because we rely on them. And what's that called? What that is called a conversational implicature. Okay, that is when you use people's assumptions that you're going to respect these maxims. It sounds complicated, it's actually really easy when you think about it. So, someone might say, "Is the supermarket still open?" I might ask you, "Is the supermarket still open?" And the answer is, "It opens tomorrow morning at 8. All right. The conversational implicature is that it's closed now, because otherwise you'd be violating the maxim of relevance. I don't care if it opens tomorrow morning, I want to know if it's open now. But because we're cooperative, the fact that you're saying that must mean, by implicature, that it's closed now. Right? And if I turn up and I walked in front of the supermarket and it was open, and I came back to you and said, "What the heck? What are you telling me? And you said, well, it is open tomorrow morning at 8. It is. You know, you'd probably get a slap. Right? And similarly, you can use that technique to deceive people. I had an anaesthetist come up to me after one of my talks and goes, you know, I used that exactly just the other day. One of my patients on the operating table asked, will I die, doctor? The real answer is very, very probably. But I didn't want to say that, so I said, I won't let you ruin my weekend. Well, what's the relevance of that? The conversational implicature is that you're going to be fine. You know? So that is a clever way to deceive people by using these assumptions, by creating these implicatures, while strictly speaking, telling the truth. And there's a big debate in moral philosophy as to, it's not that big a debate, but for people who are interested in lying and deception it is, as to whether lying is morally worse than non-lying deception. Right? So is it worse for that employee to have said, I didn't open your mail, than for him to have said, someone's been opening your mail, which is the non-lying deception. And there's lots of articles written on whether or not one is worse than the other. But interesting, in my research, my doctoral research, when I asked members of the public what they thought, they said, well, instinctively, I think lying is worse. But they couldn't really explain why. They just, you know, intrinsically thought there's something a bit worse about an outright lie than using these clever words. And it may be, I mean, some philosophers have said, well, the thing about these clever words is that if you keep probing, then you will get to the truth. You know, so it opens tomorrow morning at 8. At least it leaves open the option of the possibility of you saying, yeah, but what about now? Whereas if you say it's closed now, then it's categorical. But anyway, I don't really want to go into that in today's debates, interesting though they are. Now, I want to look at a real case again. And this is a case that sounds a little bit recondite and rare, but it is surprisingly common amongst anaesthetists. I don't know, is there an anaesthetist here by any chance? No? All right. Okay, so, beforehand, I usually ask people if they have any personal experiences of using deception in their own practice. But I'm conscious that there are actually probably quite a few lawyers here. Some of you might be involved in disciplinary work with the GMC, and it's also on camera. So I'd probably advise not to volunteer your horror stories of deceiving patients. But in the past, I've had answers like this. The patient has died, you're the doctor, you call the relatives, and you say, your son's very ill, please come as quickly as possible. Because you don't want to break the bad news when they're on the phone. Or the parent asks the doctor, did my baby suffer when he died? And as a paediatrician, you saw that the baby was in distress, unfortunately. You know that the answer you give is going to stay with these parents for the rest of their lives. What do you tell them? Or, I think this was a neurologist who was telling me, you get the biopsy result, it's bad, you call the patient and you tell the patient, we're getting the results tomorrow, why don't you come in with a friend or a relative? Because you don't want to be peppered with questions. You don't know the circumstances. You know, she may be on her own or at home or whatever. So you just lie and say, I'm getting the result tomorrow, and that immediately forecloses the possibility of, you know, tell me more. So this real-life case is a patient with a ruptured aortic aneurysm, which is rushed to the operating theatre. When someone has a ruptured aortic aneurysm, you really need to operate on them straight away if you want them to have any chance of living. And the anaesthetist knows the patient's chances of survival are poor, and just as pre-oxygenation is about to begin, just as the patient's about to go under, the distressed patient asks, I am going to be all right, aren't I, doctor? What should the anaesthetist say in this case? Can he or she justifiably deceive the patient? Now, when I was coming to the end of my PhD, my supervisor, who is a professor of medical ethics but also a GP, was a GP, said, Daniel, why don't you come up with something practical? Okay, it's all well and good to talk about these different theories, talk about these principles, and this debate between lying and not. Why don't you come up with something actually useful for doctors? And so I came up with what I called, mistakenly now I realise, I called it the deception flowchart. Okay? I should have called it the truth-telling flowchart, because deception's got such negative connotations. That I don't expect you to read this, it's going to be really tiny. But it does give you an idea of how complex it is. And the idea is that you start at the top and then you keep asking questions, and if you get to the bottom, that means your lie is, or your deception is morally justified or morally justifiable. And so I thought that could be quite helpful. Although if you're the anaesthetist next to the patient, you're probably not going to go, okay, just wait a minute, and just go through the flow chart and start. But if you have a patient in advance, or if you know a patient's going to come, or if the patient has already come, you may wish to use it. And I've had a few people email me saying they've used it. So it does hopefully work. So the first question at the top is your proposed action or omission deceptive? And immediately there's a problem here, because we already saw that you have different definitions of what is deceptive or not. When I asked you, is withholding the information from Susan deceptive, some of you said yes and some of you said no. So my advice is that if you're not sure, then just say it is a form of deception. Okay? Be uncharitable towards yourself. In fact, I think it may be easier if we use the example of the aortic aneurysm to go through the flowchart. So the first question then is, what are your justifications for the deception? And there's a list in the flowchart, and you can see it in the BMJ article, of possible good things why you would want to use deception. In this case, you might say it's to prevent great physical or psychological harm to the patient. This patient has only got probably a few seconds to live. It would be a little cruel to say, look, in my view, you're doomed or whatever. So you would lie reassuringly to prevent great harm to that patient. To preserve and enhance hope. One thing that came out a lot when I was interviewing physicians and surgeons was that how important they thought it was to maintain hope in the patient, and that occasionally required them to lie or deceive or exaggerate or underplay. Compassionate deception. I mentioned already that some people may think it's cruel to tell the truth in those circumstances. Or the patient is not emotionally or cognitively equipped to cope with the truth, as may be the case in this situation. The patient may be very scared, may perhaps even be in shock. This may not be the best time. Now, this sounds a little bit flippant and frivolous, but it is important. Given the circumstances and your assessment of the patient's mental state, is the deception attempt likely to succeed? Are you going to get busted if you lie or if you deceive, or are you going to get away with it?
Can I ask these questions on what assumption are you proceeding? In other words, what has the anaesthetist said to the patient?
Well, at this point, the anaesthetist is deciding whether or not he should tell the patient, I'm sorry, but in my view, that's it. Or, don't worry, you'll be fine, just sit back. So, he or she's using the flowchart to decide which way she's going to go.
I thought anaesthetists might say, we hope so.
Yeah, well, we'll talk about it in a second, because that's an option, which is to use a clever form of words that avoids the outright lie, but that perhaps is economical with the truth, or whatever you wish to call it. But at this particular stage, you have to evaluate, is my lie going to succeed? In this case, it almost definitely is. The patient's going to be awake, probably alive, just for a few more seconds. You're not going to get caught on this one. Okay. Now, can the objectives be met without using deception? This is where your question comes in. Can you achieve all these good things, the compassionate aspects, the prevention of psychological harm and so on, without having to lie or deceive this patient? And I'm not entirely sure that you can. I mean, yes, you can think of, I hope so, or we'll do our very best. Well, I'd be very alarmed by that kind of answer, because I probably know what it means. You would certainly need very quick thinking, very careful phrasing. It's a very high-risk strategy, in my view. And my opinion is that you just go for the outright lie. That's the safest way to do it. Again, similar thing. Will non-lying deception meet the objectives? Again, might arouse suspicion. We'll do our very best. Right, so the next point is, well, what are the objections? What are the bad things about what I'm proposing to do, about this lie or this deception? Well, it's a violation of the duty to be truthful. There are all these codes of ethics that you're breaching, including the GMC guidance, and you have the patient's right to know. So, do the justifications outweigh the objections? And unfortunately, there's no a formula for this one. You're going to have to rely on your judgment to decide which outweighs the other. My own view is that given the intensity of the distress to the patient, the fact that there aren't really any clinical alternatives in this case, you need to operate on this patient now, the fact that any delay is going to make the prognosis even worse, and the improbability of the patient in those few seconds coming to terms with the truth means that, in my view, the justifications outweigh the objections. I then have two safeguards. The first is, would you be prepared to defend your deception at a hearing of your professional body or a court of law? You can imagine the way it's going to open, the GMC guidance and page 1 of duties of a doctor, be honest and trustworthy, and so on and so forth. You would be a bit on the back foot from the start. But nonetheless, if you believe in the rightness of your decision, you may say, well, yes, I am actually quite happy to go in front of the disciplinary panel, the what is called MPTS or MT, Medical Tribunal. Help me out, anyone? It's got a new name.
Medical Assessment Tribunals.
Yes, thank you. I'm quite happy to go in front of them and to defend my position. The second safeguard is, if aware of the facts, would the patient consent to deception in advance? So it may be that you know the patient. If it were me, I'm telling you now that I would not want to be told the truth. Just say something nice and get on with it. But of course, a lot of the time you may not know this patient from Adam, and so you would ask, well, would a reasonable patient consent to me saying these things in advance? And in my view, I keep wanting to say in my submission, I always feel I'm in front of a judge, so I am in front of a judge, but in my view, the answer is probably. And then once you've gone through all these steps, the proposed deception is morally permissible. You've reached the bottom of the flowchart. Now, I phrased it really quite carefully. I put morally permissible, not morally obligatory, which means that actually there may be situations where telling the truth is also a morally permissible option. It's not necessarily the case there's only one answer. So in practice, the things to think about, the importance of the patient's perspective, ideally you want to match your disclosure to the informational preferences of the patient. Different patients want to know different things. I remember there was a practice in some of the hospices, I think it was in Wales or something, where when patients came in, they gave them a questionnaire saying, what kind of person are you? Are you the kind of person who wants to know everything? Are you the kind of person who actually really doesn't want to be involved in these things? And just to have an idea of what kind of patient they were dealing with and how much they should tell each person. Timing, incremental truth-telling. Some doctors in America are criticized for what's called truth dumping. They're so concerned, perhaps because of the medico-legal landscape, with being sued, that they just tell all the truth in one go, which obviously is not desirable from a patient's perspective. So incremental, not truth dumping. The importance of communication skills. You have these things called adverbial duties that philosophers use sometimes. So you have the question of, should you tell the truth or should you not tell the truth? And once that's the substantive question, and once you have the answer, say, yes, we will tell the truth, then you have to think about these adverbial duties. Well, who is the best person to disclose this information to the patient? When is the best time to do it? Where is the best place to do this? These are all very important considerations that must be considered as well, these adverbial duties. Self-reflection is important. If you decide to deceive the patient, what is the real reason why you want to do this? And one of the GPs I interviewed said, I wonder if some of my inherent beliefs in some forms of deception are ways of protecting me, as well as the patient, from the pain of disclosure and the consequences. It is generally a very unpleasant thing to do, to break bad news to a patient. And if you are going to use deception, you need very strong, needless to say, very strong justifications for doing so. And this is where perhaps the flowchart may be helpful, and of course discussion with colleagues and so on. Or even a clinical ethics committee. I don't know if there are clinical ethics committees, and there must be actually in the big hospitals. I'm not sure about the Chester one if you have a clinical ethics committee, but that's always a good place to go to if there is time to decide these issues. All right. Well, I don't want you to think that I believe doctors should deceive at the drop of a hat. Quite the contrary. I think it should be very rare for doctors to deceive their patients, which is why it should be really difficult to get all the way to the bottom of that flowchart. But what I did argue this evening is that there are certain moral goods, like the avoidance of extreme physical and psychological suffering, that can trump the prima facie obligation to tell the truth. And in my view, telling a lie or deceiving occasionally can represent a greater respect for persons, a greater concern for a patient's well-being than telling the truth. And so I end this lecture with a short quote from the American journalist H.L. Mencken. And it says, "For every complex problem, there is an answer that is clear, simple, and wrong." And the issue of truth-telling in medicine is, in my view, very complex, which is why clinicians and philosophers have been struggling with it for centuries, and I'm sure will continue, despite my flowchart, to struggle with it for centuries. But the more I think about the truth-telling problem, the more I'm convinced that the absolutist position that doctors should always tell the truth and never, ever deceive their patients is clear, simple, and wrong. Thank you very much. Thank you.
I just wonder what happened to Susan and her son.
Oh, I'm so sorry. I'm so sorry. No, I'm so sorry. No, with Susan and her father, I've come across this case, identical case twice. With Susan and her father, they decided to disclose the information to them. They weren't aware of it, and they were obviously taken aback, but they were happy to have been told, and the transplant went ahead as planned. Now, interestingly, the second time I came across it, it came before the Clinical Ethics Committee. And I wasn't actually available on that day, but the Clinical Ethics Committee, driven mostly by the trust lawyer, advised the liver team that they should disclose this information because of that issue of consent. And then the liver team went back to their own department and took a vote amongst themselves, and they voted 7-1 not to tell them. So they didn't tell them in that particular case. Yeah.
not as bad
Mm.
news.
Well, the difficulty with the truth-telling issue is that the doctor is generally in a state of what philosophers may call epistemic uncertainty. They just simply don't know how this particular patient is going to react. And I remember going to a book launch one day and speaking to the author who wrote a book about his stories as a GP. I was doing my PhD at the time, and he goes, "Dan, let me tell you a story about truth-telling. It was my very first visit, a GP visit. I was with my GP supervisor, and we went to this Protestant minister's house, and he had very, very advanced stomach cancer, I think it was. And my supervisor said, what we're going to do is that we're going to give him injections of painkiller and just tell him it's an infection. Okay, we're not going to tell him." And this young GP was outraged by this. This was in the 60s. He thought, well, he should know. He should be able to know this. So he went to the minister's wife and told her the truth and said, "Look, I want your permission to tell your husband that I'm afraid he's only got a couple of weeks to live, according to my supervisor." And the wife was very umming and ahhing and saying, "Well, I'm really not sure if it's a good idea," but eventually she accepted. And this young GP went to this Protestant minister and told him the truth. And this GP told me, I can still see his face to this day. He went absolutely mad. He refused all painkillers and had a horrible, horrible last few weeks of his life. He said it was the biggest mistake of my medical career. And the reason why I like this story, it just shows that we don't have a crystal ball. We don't know. You might have a patient, just like yours, who says thank you, and is appreciative and knew he was coming anyway. Or you might have a patient like this Protestant minister for whom that was an absolute disastrous revelation. And all you can do is do your best, use your judgment. Obviously, if you know the patient, then it makes it a little easier generally, but if you don't know the patient, you have to make assumptions. I'm not sure if that was helpful, but it's a nice counterpoint to your story. Well, that's it. No, yeah, well, you know.
I mean, I remember talking to one of my bosses 40 years ago who had a problem like this with a Protestant minister. And he had one of his other patients happened to be the Archbishop of Canterbury. And the Archbishop of Canterbury said, for goodness sake, don't tell him the truth. So I mean, that was
Would you be upset if I told you this is an art of market lecture? And would I be upset if I told you it was awful? I would not be upset. I would be upset, and you won't be upset. Thank you very much, Paul.
Thank you very much. Thank you.
How are you doing?
Chris. Thank you very much indeed. Another chess position, but around 10 years older. When I was first appointed 40 years ago, I shared a board with former president of the medical institution, Richard McConnell, who was a very wise and shrewd medical politician. And I was bringing all these patients onto the ward with lung cancer. And he said to me, "Did you tell them the truth?" I said, "Well, sometimes I tell a white lie." He said, "I wouldn't do that, Chris. I wouldn't do that." So I said, "Why on earth not?" And he said, "Because you'll have to remember what you told me." And I've stood by the advice ever since. And I found it very strong.
Thank you.
What do you think about that?
Thank you. Well, no, I mentioned the point in my lecture how it is very difficult these days to lie successfully to patients, and it's not uncommon for the truth to come out. And you can easily imagine the case of Susan and her father, for them going for some perhaps unrelated reason for a blood test or something of the sort in the future, and then clicking. Yes, you know, why didn't they tell us?
Thank you very much.
Yes, thank you.
Can I ask you, to what extent, you talked about truth dumping and respect, this panic, we'll just tell you everything you want to know. But to what extent did you find the problem with the opposite, which is that doctors are so terrified of saying they don't want to tell the truth, and they don't want to lie, sometimes they just sort of say nothing at all, or they use the get out as, I think that's before, or we say something which is nothing at all. So for example, being asked, a number of tests being carried out, well, what do you think it is, doctor? And the answer, well, which I've had, could be something very serious, could be nothing at all. It's not very hard to speculate there. Or just missing out bits of information because it's a bit uncomfortable to talk about it. When patients access their medical records, they then find out about it.
Yeah.
I think it's only patient forward to talk about that a lot.
About?
Just saying something without saying anything at all.
Yeah.
They're just really hiding.
They're not really answering your question. Yeah. Yeah. I guess as a patient, you just have to keep probing. But it may be that the doctor generally doesn't know. But then why can't they just say, I don't know? Well, they are in a way. Now, what's interesting with the GPs I talked to is that they did have strategies when they thought about it. They had strategies in terms of disclosure, truth-telling, for determining how much a particular patient should know or wanted to know. So they would say, they would leave clues, or they would say, for example, well, I think there's a problem with your liver. Pause. Is anything? What do you mean there's a problem with my liver? Well, I'm afraid there's this. This has come up, and it could potentially be quite serious. Pause. What do you mean quite serious? And using those kind of strategies to evaluate how much a particular patient wants to know. Is it one of those people who really wants to know it or not? But there are obvious dangers with that particular strategy, because of course there's some patients from certain cultures for whom it's extremely rude to ask questions to the doctor, and who would, even though they would want to know, don't have feel it's inappropriate to keep asking questions and to probe the doctor.